Thank you very much for the kind words. Half of them I heard, half of them I missed because I was here. So I'll check with you afterwards. I will check with you afterwards कि तारीफें थीं या शिकायतें थीं. Right. I'm here to give a talk about tics. We've covered beautifully dystonias and chorias, and now it's the turn of a tic disorder. And whenever you are preparing for a presentation, you learn a lot. So every time I go into the depth of a presentation, I come up with. I've already been introduced. I'm Dr. Khurram. My rank is Lieutenant Colonel, has been for the last 7-8 years, unfortunately, sir. Major General is too far away. But anyway, I'm trying and hopeful. This is our new OPD complex. We are very proud of it. And the first floor is the Department of Neurology. Right. So we'll be talking about tics and Tourette. Just a small introduction to the familiar scenes of basal ganglia, putamen, amygdala, thalamus, just to refresh our memory. What does amygdala do? The amygdala is connected with the development of social behaviors, our emotional memory, our social interpretation. And what does thalamus do? Thalamus is the gatekeeper of the brain. It tastes every sensation that comes in or goes out of the brain except olfaction, and sensory and emotional responses must pass through the thalamus. So having that brief introduction, let's move on to tic disorder. So what is a tic? And let me break it down for you. A tic is a sudden, rapid, recurrent, non-rhythmic, stereotyped motor movement or vocalization. So this is very important. It is sudden, in microseconds. It's rapid, it's recurrent, it's non-rhythmic, and it's stereotyped. A tic may be simple or it may be complex. Simple, involvement of a few muscles. Complex, involvement of more than a few muscles. A complicated movement if you have. So this cartoon describes a tic disorder. It's like a gentleman which has been put on vibration mode. So breaking down the classification, what's a simple tic? Generally lasting less than several hundredths of a millisecond. And what are the examples? Well, there's eye blinking, nose wrinkling, neck jerking, shoulder shrugging, facial grimacing, and abdominal tensing. So here are some examples of twitch. A hand may twitch. The patient may keep rubbing the nose again and again and sniffing, and then of course there is forceful closure of eyes. Those were simple tics. Now coming to the motor tics. They are of longer in duration than simple tics, usually lasting seconds or longer. An example will be hand gestures, jumping, touching, facial contortions, repeatedly smelling an object, squatting, retracing steps, assuming and holding unusual positions. So these will be complex motor tics. They did an analysis and they saw that the periphery, the acrals, the hand and feet, and the proximal muscles like the hips, thigh and the shoulders, these muscles were most involved in tics. So what's coproprexia and echoprexia? Both are considered complex motor tics. Coproprexia is a sudden tic-like vulgar, sexual or obscene gesture. And echoprexia is a mirror phenomena such as involuntary spontaneous imitation of someone else's movement. So the patient sees a movement and tries to copy it and repeat it. Vocal tics again can be simple and complex. They are usually, the simple ones are usually meaningless, grunting, throat clearing, sniffing, snorting. And the complex ones usually form words and even sentences. Examples can be sudden spontaneous expression of a single word which the patient keeps on repeating again and again. And there can be speech blocking and sudden and meaningless character or change in pitch, meaningless change in pitch during speech. So what are the lalias? These are example of complex vocal tics. Palilalia is repeating one's own sounds or words. A person may make a statement and then keep repeating the last few words again and again. Echolalia will be repeating the last heard sounds. The patient is in a conversation, he hears the last sound or the last few words and he starts repeating them. And coprolalia is the sudden inappropriate expression of a socially unacceptable word or phrase that may include obscenities as well as specific ethnic, racial and religious slurs. This is found in 10% of the individuals with tic disorder. So tic is described as an urge or a premonition. Tics are generally experienced as irresistible but can be suppressed for various lengths of time. Some children are not aware of their tics, but with age a premonitory urge, a rising tension or somatic sensation that is relieved with the tic. So in the words of a patient, I guess it's a sort of an aching feeling in a limb or a body area or else in my throat if it precedes a vocalization. If I don't relieve it, it either drives me crazy or begins to hurt, or both. In that way, it's both mental and physical. So they describe it like a sneeze that is about to come out, and the feeling you have before sneezing. So the patient usually has this feeling of having to tic, and the moment he does that, he feels relaxed. So how do you classify tics? There are physiological tics, which are mannerisms basically, a certain mannerism, a person keeps on seeing his watch again and again. And there are pathological tics, which are both primary and secondary. The primary are the transient motor tics, which last usually less than 1 year, and chronic motor or phonic tics, which last more than 1 year. And there is the Tourette Syndrome and adult onset tics. So basically 4 categories. The secondary are, now these are the ones which are basically in the differential diagnosis of tics, which we have to rule out before we treat the patient. Huntington's disease, these are the inherited kind. Primary dystonia, neuroacanthocytosis, neurodegeneration with brain iron accumulation, Halliburton spots, tuberous sclerosis, Wilson's disease. There are infections like encephalitis and CJD. There are drugs like stimulants, levodopa, carbamazepine, phenytoin. There are toxins like carbon monoxide. Some are developmental, in which there's mental retardation syndromes, and others like stroke, head trauma, neurocutaneous syndrome. So these are all the secondary tics which we have to rule out before labeling a patient as a primary patient. This is again an algorithm showing that tic disorder is either primary or secondary. Primary if it's transient, that is less than 1 year, and if it's chronic, it's called as Tourette, and there may be other associated comorbidities. Again, as a diagrammatic approach to the tic, it's either motor or vocal, and simple or complex, and as it becomes from transient to chronic, we reach the other end, which is the Tourette syndrome. When do tics occur? They often frequently occur when the individual is in private, not doing anything, watching TV, relaxing. And if he tries to focus on something, the tics usually go down. Tics may be exacerbated during periods of stress. So this was the start, which was tics. Now the other spectrum, as I showed, is Tourette syndrome. So George Gillies de la Tourette was a doctor who in 1875 described 9 of his patients with tic disorders and was known to have and was known to have Tourette syndrome. He labeled them to have Tourette syndrome. And this animation also shows some of the examples of tic. So what is the diagnostic criteria to label a patient as having Tourette? There is no confirmatory lab test. The diagnosis is based on a set of clinical diagnostic criteria, and the Tourette syndrome classification study group criteria for a definite diagnosis are both multiple motor tics and 1 or more phonic tic must be present at some time during the illness, although not necessarily concurrently. Tics must occur many times a day, nearly every day for more than a year. Anatomical location, number, frequency, type and complexity or severity of tics must change over time. Onset of tics before the age of 21, DMS-5 criteria recently has come out, which says below the age of 18. Previous one, it was below the age of 21. Involuntary movements and noises must not be explained by another medical condition. Motor tics, phonic tics, or both must be witnessed by a reliable examiner at some point during the illness. Other terms that people have used to describe Tourette's are chronic motor vocal tic disorder, transient tic disorders, but preferably it's called Tourette. It's known to affect boys more than girls. Mean age of onset is between 6 and 7 years and affects 2% of the general population in the West. This is a very interesting disease spectrum which can compete with Tourette, but it has a cause. It's called pediatric autoimmune neuropsychiatric disorder associated with strep, PANDAS. A possible cause of OCD and Tourette in patients. It's basically related to group B streptococcal hemolytic infection in selected individuals. How they found out? They took the antibodies, they injected a rat, and the rat developed tic-like behavior. Basically, we can't really find anything on a CT or MRI of a patient with Tourette. It doesn't show any structural lesions, gross structural lesions. But functional MRI with SPECT, PET, and functional MRI shows deformities. We don't readily have these modalities. So in pathogenesis, there's an anatomical area which is involved, which we can see through a functional MRI. Biochemically, dopamine is considered to be the chemical which is causing the problem. There is a genetic association, and there's an immunological variant called PANDAS. Now, TS is related to a lot of comorbid conditions which occur very frequently with this disorder. ADHD 50 to 75%, now that's a very high rate. As we are usually seeing Tourette in teenage, adolescence and young age, we have to keep in mind that these comorbidities are definitely associated with this disease. OCD up to 70% of patients. Anxiety disorders 20 to 80%. Mood disorders 20 to 80%. And patients with academic difficulties 50%. So we have to know a little bit about these diseases because TS, ADHD, OCD have no biological tests. So it's mainly a clinical diagnosis. They evolve in childhood. Standard diagnostic criteria used doesn't apply. Impairment defines the condition. Diagnosis and treatment take time. So if you see the spectrum, OCD and ADHD have a main role in the association of Tourette. And broadening the spectrum, there's almost half of the psychiatric ailments like anxiety and depression which have fallen into this group. So we have to know a little bit of these ailments, these comorbidities which are related with Tourette's, if we have to identify the disease and treat it successfully. So patients with ADHD will have quick temper, overreaction, mood changes, difficulties with impulse control, oppositional behavior, defiant behavior. With OCD, we will have obsessions. He will obsess over small things again and again. He will have compulsions. He will have irresistible urges to have ritualistic acts, and it waxes and wanes with TS. Mood disorders, quite obvious. Usually with Tourette's, the patient has lags behind in academic and school performance, writing disorders, comprehension disorders, maths disorders, visual motor integration is always affected. Now, coming to the treatment, you have a tic disorder, It has been going on for more than 1 year. It involves motor and phonic features. You label it as Tourette. You identify whether the patient has OCD, ADHD associated with it. How do you treat it? The first is education, educating the patient, educating the family, counseling the patient, counseling the family, relaxation therapy, supportive therapy, and habit reversal therapy. So I'd like to say a few words on habit reversal therapy. It's a behavioral therapy called HRT, may be effective for improving tics and controlling symptoms in Tourette. HRT consists of two main components: tic awareness training, which teaches a patient to recognize early signs that precede the onset of a tic; competing response training, which teaches patients to perform a voluntary movement that is incompatible with a particular type of tic. First, you have to tell the patient that when he feels this urge to tic, that when the tic is coming on, he should have a similar competing response and a dissimilar competing response. So a patient who is clenching his arm, for example, a similar competing response will be that you will ask him to try to straighten his arm using the same muscle except antagonist group, and a dissimilar competing response would be that you tell him to stretch the left calf of his left leg. So you are basically teaching the patient that when he is about to tic, try to extend your right arm and try to stretch your left calf. This way, probably he's not going to tic. If he's going to have the tics very frequently, if he has this problem frequently, he may not be able to do it every time, but this is part of HRT. Then there's a pharmacological treatment. If it's mild, we just go for HRT. If it is bothersome or falls in the spectrum of Tourette syndrome, tetrabenzamine, fluphenazine, and risperidone are the drugs. Quickly going over the drugs: anti-dopaminergic drugs like fluphenazine or risperidone have been used frequently. Tetrabenzene, starting at 12.5 milligram, is now more popular. Sometimes availability is an issue, but it is available and has better results, does not have tardive dyskinesia, and is much better than haloperidol. You can also try alpha adrenergic agonists like clonidine. Topiramate in a short span has come up and has shown some evidence, and then botulinum toxin injection can also be used. In cases in which the medicine, HRT and medicines are failing, you can go for DBS, and basically the stimulation site is GPI, globus pallidum, and this is how it looks like with the battery under your clavicle and the electrode inside the GPI and thalamic nuclei. I was preparing for this presentation and I came across this video. It's 5 minutes long, and I think it's self-explanatory. Basically, a group of children have gotten together who have Tourette syndrome and made this video for the general information, and I think it more or less summarizes all of my talk.
What are tics? Would you know a tic if you saw one? Hi, I'm Pearson. I'm 10 years old and I have Tourette syndrome.
Hi, my name is Caleb. My name is Brianna. My name's Emily. And I have Tourette's. But Tourette's doesn't have me. I have Tourette's, but Tourette's doesn't have me. And I have Tourette's, but Tourette's doesn't have me.
Tourette is one kind of tic disorder.
Tics are involuntary movements and sounds that I can't control.
Sometimes you might not see my tics, but I still have Tourette syndrome.
Only 5 to 10% of people with Tourette's have swearing tics.
What I wish people knew about Tourette's is that we can't control it. It's not contagious, it's not life-threatening, and there is no cure.
By jerking.
Shoulder shrugging. Arm movements. Hitting. Leg lifting. Body jerking.
Vocal tics are involuntary sounds. Some examples of vocal tics are
Throat clearing. Sniffing. Animal noises. Blowing.
Saying words or phrases.
apple, 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 pomegranate,
Screaming.
So the last slide are the words from a parent of a child who has Tourette. I won't change the way my child views the world. Instead, I will change the way the world views my child. Thank you.
We'll open the house for questions.
Sorry? How do I manage these tics? Tetrabenzamine if it's available, and Respirodol. Haloperidol has a lot of side effects, and this therapy, this replacement therapy, and this basically distraction therapy, as I call it, you have to sort of teach them that before behavioral therapy, that before they take, and then looking for the association with ADHD or obsessive compulsive disorder. Usually these children are not faring well in school, and they're not doing well with their peers, and that is aggravating their symptoms. So you have to sort of give them sometimes atypical antipsychotics even, and sometimes asking for a little bit of advice from the psychiatrist, because up to 60 to 70% have relationship or association with these comorbidities. So simple tics are usually easy to pick up. And another thing for the audience is that when you are examining tics and you're not sure you're dealing with tics, one thing about a tic is that the patient can sort of sustain it. So what I do is I say I'll count till 10 and you will not tic, you will hold this movement. So a patient with chorea or patient with tremor, they try, but after the 4th or 5th second, I usually tell the patient to count himself. The 4th or 5th second, it is uncontrollable, but with a tic, it is suppressible. And then the moment you say, okay, 10, they start ticking quite rapidly.
have a question. As concerning your last slide, you have to change the perception of the world regarding regarding the it's on. So my question is, when you stop the medication for the child, because this child is going to suffer for the rest of his or her life. So is it rational to give medicine to such a patient or not to give medication to such a patient?
Sir, it's stepwise. I mean, you can start with cognitive therapy and behavioral therapy, but if he's not responding, then it's best to intervene. And if you don't want to treat the tic individually, you can treat the ADHD and OCD and the anxiety element of it, and the tics will improve by themselves. But it is an issue because he's a child and he is going to grow up and the disease is going to stay with him, and people are going to make fun of him, and you can't sort of keep him on medicine for a very long time. So what I do is I take the psych view, the psychiatry comorbidity first, and also then treat the tic. The tic treatment you can take off after some time, and they also learn by these tricks and behavioral therapy to control themselves, and it's quite successful because the young teenagers who can understand, I've tried this thing of telling them to clench their hand or clench their leg, and they can sort of suppress it when in school or when in public.
Sometimes the simple tics occur transiently. You just transient tics phenomena occur for a few weeks when they are under enormous stress. So that you can get away with simple psychotherapy and benzodiazepine.
Yes.
Now my question is that panda syndrome. How will you prove this is panda? And will you treat them like you will treat Sydenham chorea, that you put them on chronic therapy for the rheumatic heart disease?
So that's a very difficult question, but because of the rheumatic chorea that we get, streptococcal infections are quite common, and even if you get anti-streptococcal antibodies, you're not sure whether that is the reason they are having these tics. It's important to diagnose those patients. Why? Because it's treatable. You give them immunoglobulins and they are going to improve. Pandas is one variant which is going to respond to treatment. How you can differentiate it from a chorea, maybe clinically, or maybe with the ASO titer, I'm not sure. I haven't come across pandas as it is, but rheumatic chorea is quite frequent in children that we get to see every time. One way to go about it is that you treat it as rheumatic chorea, and if you are not getting any response and you feel it's not coriform and more of a tic, then you can give him a trial of immunoglobulins. It's not going to harm him in any way, and if he improves with it, because that's a one-time measure, you don't have to repeatedly give them immunoglobulins.
Thank you, Dr. Khurram. Before we conclude, I have an announcement. I would say that this session was movement disorders made easy. Honestly, they made it so simple, so easy to understand. हो सकता है कल मैं भूल जाऊं, but for now it seems like it's very easy, and it's easy to manage as well, which I always had difficulty. I think with this I will end the session here.